Hi friends, today I will talk about supraventricular tachycardia. As we know, this is a medical emergency. First is a disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. Supraventricular tachycardia is an abnormally fast heart rhythm which originates from the areas above the ventricles, typically involving the atria or the atrioventricular node. The heart rate usually ranges between 150 to 250 beats per minute, and it is often caused by abnormal electrical circuits in the heart. Episodes that occur with sudden onset and terminates are referred to as paroxysmal. Paroxysmal means from time to time. So pSVT, it is correctly seen in reentrant tachycardia involving the AV node such as AVNRT or atrioventricular reentry tachycardia. The various types of SVT, depending upon their mechanism, can be classified based on the location and the mechanism of abnormal rhythm, and the types are atrioventricular nodal reentrant tachycardia, that is AVNRT. It is most common form of supraventricular tachycardia. It is caused by re-entry circuit within the AV node. The electrical impulses circulate rapidly within the AV node, causing the heart to beat faster. The atrioventricular reentrant tachycardia, it is the second most common type. It occurs when accessory pathway, that is extra conduction pathway, allows electrical signals to bypass the AV node and forms a re-entry circuit. It is seen in Wolff-Parkinson-White syndrome with delta waves in the ECG. Next is the atrial tachycardia. Here the impulses, they originate from single focus in the atria outside the SA node, and it is caused by abnormal automaticity or micro re-entry circuits in the atria. The multifocal atrial tachycardia means multiple foci, they originate in the atria which generate impulses and they result in irregular heartbeats, and it is often associated with lung disease or electrolyte imbalances. The SVT can be classified based on the site of origin, that is whether it originates from atria or the AV node, or they can be classified based on their regularity, whether they are regular or irregular, and thirdly based on the width of the QRS complexes. The classification which is based on QRS width is unhelpful, as this is also influenced by the presence of pre-existing bundle branch block, rate related aberrant conduction, or presence of accessory pathways. So the classification of the supraventricular tachycardia by the site of origin and regularity, based on the site of origin, when they are atrial, they can be regular atrial or irregular atrial. When they are atrioventricular, then we call them as regular atrioventricular. The regular atrial examples are sinus tachycardia, atrial tachycardia, atrial flutter, inappropriate sinus tachycardia, sinus road, reentrant tachycardia, irregular atrial or atrial fibrillation, atrial flutter with variable block, multifocal atrial tachycardia. And the regular atrioventricular are AVRT, AVNRT, automatic junctional tachycardia. So based on the QRS complexes, they can be narrow QRS complex or wide QRS complex. Narrow QRS complex is when the width is less than 120 milliseconds, and wide when the width of the QRS complexes is more than 120 milliseconds. The narrow QRS complexes and the wide QRS complexes can be regular or irregular. Regular narrow QRS complexes are seen in supraventricular tachycardia, that is atrioventricular reentry tachycardia, and the atrioventricular nodal reentry tachycardia. And irregular narrow complex tachycardia are seen in atrial fibrillation, atrial tachycardia, or flutter with variable conduction block, multifocal atrial tachycardia. Wide QRS complex tachycardia regular are seen in ventricular tachycardia, SVT with aberrancy. Irregular wide QRS complex tachycardia are seen in atrial fibrillation with aberrancy, polymorphic VT, and torsady pointes. This is the another classification of the supraventricular tachycardia, which is given in the Harrison, and I have already discussed in detail. The pathophysiology involving the supraventricular tachycardia, as we know that SVT occurs due to abnormal electrical impulses originating above the ventricle, typically in the atria or the AV node, leading to rapid heart rate, that is tachycardia. The underlying mechanism are re-entry circuits, abnormal automaticity, and triggered activity. The normal electrical conduction in the heart follows that SA node in the right atrium generates the electrical impulses because it is a natural pacemaker. The impulse then spreads through the atria, causing the atrial contraction. It then reaches the AV node, which slows the conduction, allowing the ventricle to fill with blood. The impulse then travels through the bundle of His and Purkinje fibers, leading to ventricular contraction. The mechanism of supraventricular tachycardia are most common is the re-entry, that is, it is seen in 90% of the cases. Re-entry occurs when abnormal electrical loop is formed, allowing the continuous activation of the atria and the ventricle. The types of re-entry circuits in supraventricular tachycardia are atrioventricular nodal re-entrant tachycardia. We call it as a AVNRT. It involves two pathways within the AV node, fast and slow. The impulse gets trapped in a circular loop, leading to rapid, repetitive heartbeats. Next is the atrioventricular reentrant tachycardia, that is AVRT. It involves the accessory pathway, means here the extra electrical connection occurs between the atria and the ventricle, which bypass the AV node. For example, Wolff-Parkinson-White syndrome. Here we see a bundle of Kent which acts as a accessory pathway. SVT can occur because of abnormal automaticity. The heart cell outside the SA node, they start generating the impulses abnormally, and this leads to a rapid unregulated heartbeat, and it is seen in atrial tachycardia, multifocal atrial tachycardia, which is due to hypoxia, electrolyte imbalances, or lung diseases. SVT can occur because of triggered activity after depolarization. For example, abnormal ion flow in the heart cell causes extra beats after normal heartbeats. This can trigger SVT episodes, usually seen in conditions like digoxin toxicity or electrolyte imbalances, especially the calcium abnormalities. The consequences of SVT are reduced cardiac output due to rapid heart rate, ventricles they do not fill completely, and which reduces the blood pump to the body. Patient can have hypotension, dizziness, and in severe cases, decreased cardiac output leads to very low blood pressure. Because of decreased myocardial oxygen demand, because of prolonged tachycardia, it can cause chest pain, even worsening of the heart disease if there is any underlying heart disease. Coming to the AVNRT, that is atrioventricular nodal reentry tachycardia, it is most common form of supraventricular tachycardia. It occurs due to circular electrical signals, that is reentry circuits, within or around the atrioventricular node, causing the heart to beat faster than normal. A regular narrow complex tachycardia at 150 beats occurs, mostly average is 140 to 280 beats per minute, and it is regular in nature. It may self-resolve or continue indefinitely until the medical treatment is sought. The AV node is a small cluster of specialized heart cell. We know that it is located in the interarterial septum near the center of the heart. It plays a crucial role in the electrical conduction by delaying the electrical impulses from the atria before passing into the ventricle. The AV node has two conduction pathways, slow pathway and the fast pathway. Slower conduction occurs in slow pathway, but it recovers very quickly. The fast pathway, here the faster conduction occurs, but the recovery is slow. Under normal condition, the impulses from the SA node travel through both pathways without any issue. So coming to the pathophysiology or the mechanism of the AVNRT, AVNRT occurs when an electrical impulse gets trapped in the re-entry circuit within the AV node, which leads to rapid heart rate. Step-by-step mechanism is the premature atrial contraction triggers the AVNRT, means a PAC, premature atrial contraction, arrives early while the fast pathway is still refractory, means it is not ready to conduct. Instead, the impulse is conducted slowly by the slow pathway as shown in the figure. The impulse travels retrogradely, that is backward by the fast pathway. By the time the impulse reaches the ventricle, the fast pathway has recovered. The impulse loops back up to the fast pathway to the atria, creating a circular re-entry circuit. Continuous re-entry results in tachycardia. The circuit repeats rapidly, stimulating the atria and the ventricle simultaneously, causing a regular rapid heart rate, usually in the range of 150 to 250 beats per minute. Usually, we see two types of AVNRT depending upon the direction of the impulse conduction. Slow, fast AVNRT, it is seen in 90% of the cases. Here, and the pathway used is down the slow pathway up to the fast pathway, and it is most common. Here in ECG, P waves are hidden in the QRS or they appear as a pseudo S wave in lead 2-3 AVF. The fast slow AVNRT, it is atypical AVNRT. It is in 10% of the cases. Here we see down the slow pathway up to the slow pathway. It is less common. Here the P waves, they are visible after the QRS complexes, and here we see a longer RP interval. So typical AVNRT, that is slow fast, is more common and it results in narrow QRS tachycardia with hidden P wave. Atypical AVNRT is rare and has a slightly longer RP interval due to retrograde P waves. The ECG features in the AVNRT are regular narrow QRS complex tachycardia. Heart rate is 140 to 280 beats per minute. Narrow QRS complexes, P waves are often hidden within the QRS complexes. P wave, if visible, they exhibit retrograde conduction with the inversion in lead 2-3 AVF. P wave, they appear just after the QRS as a pseudo R wave in lead V1 or pseudo S wave in lead 3. The RP interval is shorter than 70 milliseconds. The key point is if the QRS is wide, consider AVRT because patient may have Wolff-Parkinson-White syndrome or aberrant conduction. The clinical features of AVNRT are palpitation, dizziness, shortness of breath, chest discomfort or tightness, anxiety, syncope, and the triggering factor are emotional stress, caffeine, alcohol, nicotine, physical exertion, fever, dehydration, and certain medication like beta agonist. AVNRT is more common in young females and it can be triggered by the triggering factor like stress, caffeine, alcohol, exercise, emotions. Diagnosis of AVNRT is based on the ECG, shows regular narrow QRS tachycardia and other features which I have already discussed. Holter monitoring is done for patients with intermittent episodes, and we can do electrophysiological studies also, and when it is used when diagnosis is unclear or before catheter ablation. It may help map the re-entry circuit inside the AV node. The management of AVNRT is for acute treatment. We have to stop the ongoing episode. The goal is to interrupt the re-entry circuit and restore the normal rhythm. Here we do the vagal maneuvers like it is a first line non-drug therapy. Here we stimulate the vagus nerve, slowing the AV node conduction and stopping the re-entry. The techniques involve Valsalva maneuver, that is forceful exhalation against a closed mouth or nose. Carotid sinus massage can be done. A gentle neck pressure is given, but it is avoided in the elderly due to stroke risk. Cold water face immersion creates a diving reflex and it slows the heart rate. Uh, for pharmacological treatment, adenosine is the drug of choice. For acute termination, we give the rapid IV push 6 milligram. If there is no relief, then we can repeat 12 milligram. It temporarily blocks the AV node, breaking the circuit. But the side effect of it is flushing, chest tightness, dizziness, and we have to avoid it in patients with heart block. Beta blocker, calcium channel blockers, they are alternative to adenosine. Patients with we can use metoprolol, diltiazem, verapamil. I have discussed these things in detail in the management of SVT. They can slow down the AV conduction and they are used if adenosine is contraindicated or ineffective. Electrical cardioversion for unstable patient. If hypotension, syncope or chest pain occurs, immediate synchronization cardioversion 50 to 100 joule is required. The long term management means to prevent the recurrences, we have to do lifestyle modification. We have to avoid the triggering factors like caffeine, alcohol, stress. Beta blockers or calcium channel blockers are required for frequent episodes. Catheter ablation is a definitive cure. It cures the 95% cases. Success rate is 95%. Radiofrequency ablation destroys the slow pathway in the AV node and it is recommended for symptomatic or recurrent cases. It has a very good prognosis, not life threatening in most cases, curable with catheter ablation. 95% is a success rate and it has a very less than 1% complication rates. If untreated, the episode may recur but rarely cause any long term damage. So, to summarize, the AVNRT mechanism is the re-entry circuit in the AV node, slow fast or fast slow. ECG findings are narrow QRS, hidden or pseudo P waves, regular rhythms. Patient may have palpitation, dizziness, shortness of breath, anxiety, and treatment is vagal maneuvers followed by adenosine or beta blockers. And in unstable patient, we have to do the cardioversion. Long-term treatment is beta blocker, lifestyle changes, and catheter ablation, which is curative. Coming to the atrioventricular re-entry tachycardia, here the early activation of the ventricles occurs. The impulse they bypass the AV node through an accessory pathway through bundle of Kent. It is called Wolff-Parkinson-White syndrome. This re-entry circuit causes rapid and regular heartbeat, usually between 150 to 250 beats per minute. The PR interval is less than 120 milliseconds. Delta waves occurs and this is a slurring or slow rise of initial portion of the QRS complexes. It is called delta wave. The QRS prolongation is more than 110 milliseconds. The RP interval is longer than 70 milliseconds. ST segment and T wave discordant changes and QRS alternance can be seen. V1 is positive in left accessory pathway and negative in the right accessory pathway. Pseudo infarction pattern can be seen in 70% patients due to negatively deflected delta waves in the inferior or the anterior leads, that is pseudo Q waves, or as a prominent R wave in V1 to V3, which may mimic the posterior infarction. The ECG features, they depend on the direction of the conduction, which can be orthodromic or antidromic. It is seen in Wolff-Parkinson-White syndrome with delta waves in the ECG. AVRT can be orthodromic AVRT or antidromic AVRT. Most common is the orthodromic. Here the impulses they travel down the AV node, they reach the ventricle, then return to the atria by the accessory pathway. We see narrow QRS complexes on ECG since the normal conduction system is used to activate the ventricle. Examples are concealed accessory pathway, no pre-excitation is seen. Antidromic AVRT is rare, it is seen in 10% of the patients. The impulses travel down the accessory pathway, they reaches the ventricle below the AV node, then return to atria by the AV node. Wide QRS complexes are seen on ECG because the ventricles they are activated abnormally. Example is Wolff-Parkinson-White syndrome, which shows pre-excitation on ECG. Pathophysiology of the AVRT is presence of an accessory pathway between the atria and the ventricle, the normal electrical conduction moves only through the AV node to the ventricle. In AVRT, an impulse can travel in a loop between the AV node and accessory pathway, causing the tachycardia. The reentrant circuit continuously stimulates the atria and the ventricle, which results in rapid heart rate. The accessory pathways in the AVRT are bundle of Kent, that is classical seen in WPW syndrome. It is a direct connection between the atria and the ventricle, and less common pathway is the Mahan fibers. The ECG findings in the AVRT, in orthotromic AVRT, we see narrow QRS complexes tachycardia. Retrograde P waves may be hidden in the QRS or after QRS. Short RP interval P wave follows the QRS closely. Enterotomic AVRT, which is rare 10% cases seen. Wide QRS tachycardia is seen. Delta waves in the WPW syndrome due to pre-excitation, and we can see short PR interval because of early activation of the ventricles. The clinical features of the AVRT are sudden onset and termination like AVNRT. Patient may have palpitation, dizziness, syncope due to rapid heart rate, chest discomfort, anxiety, breathlessness can be seen. Patient may present with WPW syndrome if delta waves are present. Diagnosis of the AVRT: in ECG, we see narrow or wide QRS tachycardia. Holter monitoring if patients have episodes which are infrequent, and the electrophysiological studies can be done to confirm the presence of accessory pathway. The management of the AVRT is similar to that of AVNRT. We do vagal maneuver. Adenosine is the drug of choice. We can give beta blocker, calcium channel blocker if adenosine fails, and in unstable patient we can do cardioversion if the patient has unrecordable BP, shock, or a patient is unconscious. Long-term management is prevention of the recurrence by avoiding the triggers. Beta blocker, calcium channel blockers are used in recurrent cases, and the definitive cure is the catheter ablation, which destroys the accessory pathway with 95% of the success rate. The key differences between the AVRT and the AVNRT: in re-entry location in AVNRT is AV node. In AVRT, it is the accessory pathway. In AVNRT, we get narrow QRS complexes. In AVRT, we get narrow or wide QRSs. It is seen in young adults in AVNRT, and patients with AVRT will have WPW syndrome. Treatment is almost same. So just to summarize, the clinical features of supraventricular tachycardia are palpitation. Patient may have sudden onset palpitations, and it also subsides by its own. Patient may have syncope when the ventricular rate is very high. Patient may have chest pain if underlying ischemic heart disease. Patient may have hypotension, and this decides the management, and patient can have worsening of the heart failure. Coming to the investigation, we will do the ECG. It can identify most of the tachycardias. Holter monitoring may be required for diagnosing paroxysmal or intermittent SVT. Echo is done to rule out structural heart disease. Similarly, we can do electrophysiological study to assess the accessory pathways. So in ECG, we usually do a stepwise approach. In SVT, first we don't look at the P waves, we look at the ventricular response to whatever is going on in the atria. And we have to ask ourselves, is the QRS complexes is wide or narrow? Are the QRS are regular or irregular? Was the onset sudden or slow? Then we have to look for P wave. If P waves are present, and P wave follows the QRS in AVRT. In all other SVTs, they precede the QRS. No visible P waves are seen in AVNRT. They are hidden within the QRS complexes. In SVT with rapid ventricular rate, P waves are often obscured by the T waves but may be seen as a hump on the T wave. In narrow QRS complexes SVT, when tachycardia has a narrow QRS complex, it is much easier to diagnose it as a supraventricular tachycardia. The wide QRS complex tachycardia, here the origin of the wide QRS tachycardia can be either atrial if bundle branch block or accessory pathway is present, We call it as a SVT with aberrancy, or it could be VT or VFib. So they are trickier and often more dangerous. This is the algorithm. If we find a patient with narrow QRS tachycardia, we have to see whether it is regular or irregular. If it is regular, we have to see whether P waves are visible or not. If P waves are visible, then atrial rate greater than ventricular rate, yes, it could be atrial flutter or atrial tachycardia. If atrial rate is less than ventricular rate, we have to analyze the RP interval. If RP interval is short, it is shorter than PR interval, then if RP is shorter than 70 milliseconds, it could be AVNRT. And if RP is longer than 70 milliseconds, it could be AVRT, AVNRT, atrial tachycardia. If a RP interval is long, that is, it is longer than PR interval, it could be atrial tachycardia or PJRT or atypical AVRT. If P waves are not visible, then it could be AVNRT. So if we don't find any regular tachycardia, if it is irregular, it could be atrial fibrillation, atrial tachycardia, or flutter with variable AV conduction or multifocal atrial tachycardia. So management of the SVT is based on whether the patient is stable or unstable. If the patient is unstable with the shock, unconscious patient, we usually do the synchronized cardioversion. For narrow regular QRS complexes or narrow regular SVT, we give 100 to 200 joules of uh, cardioversion. Narrow irregular, we give 100 to 200 joules. Wide regular, we give 200 joules. Wide irregular, we give 200 joules. And defibrillation dose is given. For unstable patient, if hemodynamically compromised patient, R wave synchronize DC cardioversion using 100 to 200. I have already discussed this, 100 to 200 joules. But we have to begin at 100 joules. It can terminate most of the tachyarrhythmias. So electrical cardioversion, also known as direct current or DC cardioversion, it is a procedure whereby synchronized electrical shock is delivered through the chest wall to the heart through special electrodes or pedals that are applied to the skin of the chest. The purpose of the cardioversion is to interrupt the abnormal electrical circuits in the heart and to restore a normal heartbeat. The delivered shock causes all the heart cells to contract simultaneously, thereby interrupting and terminating the abnormal electrical rhythms, typically that of atria, without damaging the heart. The heart's electrical system then restores a normal heartbeat. Cardioversion of the patient with implanted pacemaker or defibrillator devices is safe when appropriate precautions are taken. We have to keeping the cardioversion pads in AP orientation. It ensures that shocks are not directly over the generator. For hemodynamically stable patients, we have to connect the patient to ECG monitor. First of all, we have to do the vagal maneuvers because they increase the vagal tone. The vagal maneuvers which are usually followed are, we have to ask the patient to exhale forcefully against a closed glottis for 10 to 15 seconds in a supine position. Ask the patient to blow into a syringe with a closed nozzle or into a balloon. We can do carotid sinus massage. We have to locate the carotid sinus beneath the inferior angle of the mandible at the level of thyroid cartilage and massage using a thumb for 5 to 10 seconds. If no response is seen in 30 seconds, we can try it on other side. But we have to avoid it in elderly or in patients with previous TIA or if there is any carotid bruit is noticed. And among the drug therapy, adenosine is the drug of choice. Initially 6 milligram rapid bolus or push is given over a period of 1 to 2 seconds. If it is not effective within 1 to 2 minutes, then we can give 12 milligram, and we may repeat 12 milligram bolus if needed. Maximum single dose is 12 milligram. Each IV bolus of adenosine should be followed by 29 ml of normal saline flush. And if we are giving it to us by the center line, we have to use the half of the dose. Adenosine must be used in caution in patient with asthma, COPD, because it can promote the bronchospasm. Similarly, the dose of verapamil is given as IV 5 to 10 milligram over 2 to 3 minutes 10 milligram may be repeated in 30 minutes if needed. Then 2.5 to 10 milligram per hour infusion can be given. And similarly, thereafter we can use oral like 120 to 360 milligram per day, and the starting dose is 40 milligram per oral TID. We can give diltiazem IV 0.25 milligram per kg over 2 minutes. The average dose is 20 milligram. It can be repeated as 0.35 milligram per kg and average of 25 milligram given over 15 to 30 minutes. Similarly, we can give metoprolol IV as 2.5 to 5 milligram bolus over 2 to 5 minutes. If no response, additional 2.5 to 5 milligram IV bolus can be given over 10 minutes. Up to 3 doses, maximum dose, total dose of 15 milligram can be given. Thereafter, we can give per orally 25 to 100 milligram. Amiodarone can be given in wide complex tachycardia IV 15 milligram per minute for 10 minutes, that is 150 milligram in 100 ml, 5% dextrose over 10 minutes. Then continue infusion 1 milligram per minute for 6 hours, then 0.5 milligram per minute for 18 hours, diluted in 5% dextrose. Then per orally 100 milligram or 200 milligram BD can be given. Similarly, we can use esmolol as 1 milligram per kg IV bolus over 30 seconds, followed by a 150 microgram per kg per minute infusion if necessary. Infusion rate adjusted to maintain the desired heart rate. Up to 300 microgram per kg per minute can be given. For WPW syndrome, the treatment is same. We can use IV procainamide can be added if the treatment is refractory. We have to avoid digoxin even in AF patient as it may increase the ventricular rate. Avoid adenosine and other AV blocking agents like digoxin in WPW syndrome also. The radiofrequency ablation, we have to refer the patient to electrophysiologist, and there we can do catheter ablation if recurrent, dangerous or refractory patients are there. So this is a narrow complex or wide complex tachycardia. How do we have to deal this patient? For narrow complex, vagal maneuver followed by adenosine, then beta blocker, calcium channel blocker if necessary. For stable narrow complex SVT is the treatment protocol. This protocol can also be used for wide complex tachycardias that are definitely regular, that is SVT with RBB or LBB. Stable irregular wide complex tachycardia are usually Wolff-Parkinson-White syndrome or SVT or AF with apparent conduction. Here, adenosine should not be given as it can induce ventricular fibrillation in these patients. Diltiazem, verapamil or beta blocker should also not be used here. Antiarrhythmics such as amiodarone, procainamide, ibutylide, lidocaine, sotalol are safer and more useful agents for stable wide QRS complexes, irregular tachycardias. This is a algorithm. If patient with regular supraventricular tachycardia comes to us, we do vagal maneuvers or we give IV adenosine. It is a class 1 indication. If it is ineffective or not feasible and the patient is hemodynamically stable, then we can use IV beta blockers, IV diltiazem, IV verapamil. If patient is hemodynamically unstable, we will have to give synchronized cardioversion. If the pharmacological treatment is ineffective in hemodynamically stable patient, then there also we can use synchronized cardioversion is a class 1 indication. This is algorithm for adult tachycardia with pulse algorithm. Here we assess the appropriate for clinical condition heart rate typically more than 150 beats per minute. If tachyarrhythmia is there, identify and treat the underlying cause, maintain patent airway, assist breathing as necessary, oxygen if patient is hypoxemic. Cardiac monitor is applied to identify rhythm, monitor blood pressure and oximetry. If patient has a persistent tachyarrhythmia causing hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, acute heart failure, means patient is unstable, we can give synchronized cardioversion. We have to consider the sedation before giving synchronized cardioversion. If regular narrow complex tachycardia is there, we can consider adenosine also. If the patient is stable and patient has a wide QRS complexes, then we can have IV access 12 lead ECG monitor connected to the patient. Consider adenosine. If the patient has a irregular and monomorphic complexes, consider antiarrhythmic infusion. Consider expert consultation. Similarly, if the patient has wide QRS complexes, patient doesn't have the white QRX complexes, there we can use vagal maneuver, adenosine beta blocker. I have already discussed these things. Similarly, this is the algorithm which we can remember also. So medicine is an intention. Those who are proficient enough at using intentions are good doctors. It was said by San Simio. With this, I conclude my today's topic. Thank you. Keep learning.